I'd now like to invite Dr. Louise Newson onto the stage, who is a GP and menopause specialist and writes very passionately about improving awareness of safe prescribing of HRT. She also has a website, Menopause Doctor, and recently opened a Menopause and Wellbeing Centre in Stratford-upon-Avon. Louise.
Sorry.
You okay?
Yeah, well, I've been...
Just get flies.
So I feel very privileged to be standing here today. Michael Bown has been he's my guru. I read about him a long time ago when I was a junior doctor, and I feel very starstruck that I'm here to see him today. So I'm a GP. I've been a GP for a long period of time, but I've also had a portfolio career because my husband's a surgeon and I've got 3 children, and I'm always constantly juggling things. And I've always done a lot of medical writing for the press, but also for doctors as well, to get more information, because without anything we do in medicine, without the right information, we can't make the right decisions and we can't give the patients choice. So this is my Menopause Doctor website that I set up about 18 months ago, just because I was quite shocked as I got older, and my friends were getting older, that they didn't know anything about the menopause, which happens to all women if we live long enough. It's not a disease, as we quite rightly know, but it can lead to diseases if it's not managed properly. So I set this up a while ago, and I've been staggered with the amount of attention that it's had. It's about 15% US. The last figures, there are about 250,000 people that view it on a regular basis. And it's for doctors as well as for women and men as well. So these are my declarations of interest. I also have another one in that I do take HRT. And if I wasn't taking it, I wouldn't be standing here today. I'd probably be at home in my pyjamas feeling very sorry for myself. So I've recently opened a Menopause and Wellbeing Centre, and I'm ashamed to say that it's a private centre. And in the UK, menopause services on the NHS are being slashed left, right and centre. There's no funding from my CCG for me to do any menopause work. And so I've set this up with other GPs to provide a very holistic approach to the menopause. So there's doctors, but there's also other services as well, including a yoga studio, which I'm very proud of because I really enjoy yoga. So I'm going to make this real. So this is a lady who has given me full consent to share her picture. And she actually came as a complaint one day to my practice. There were 2 GP practices where I was working, and she came from the other practice. I'd never met her before. And she put in her husband put in a formal complaint because she wasn't getting anywhere with the NHS, and they were really hacked off. And somebody said, oh, go and see Dr. Newson, because a lot of women go and see her and come out feeling really good. So she came to see me, and I was quite scared because she looked a bit like this and was very miserable. She's only 38, and she just said, look, I generally feel dreadful, no one's listening to me. I feel more tired, I've got no energy. I've had migraines for a long time, they've got a lot worse. They're getting closer together, they're more severe. And she'd been seen under the migraine clinic. There's a really good migraine clinic in Birmingham, and she'd been seen various times. She'd been given usual analgesics, painkillers, but she'd also been given some heavy-duty drugs. Sometimes we use anti-epilepsy drugs for migraine. She'd been on them all, and they'd all caused side effects for her. And actually, this selfie she took before her last clinic appointment in the menopause clinic, in the migraine clinic, and said to the doctor, what are you going to do about this? I feel dreadful. You're not making me any better. And he said, well, there's nothing else we can do, hence the complaint. She'd also had loads of urinary tract infections. She'd had a lot of urinary symptoms. She couldn't cough or sneeze very easily. Certainly couldn't bounce on a trampoline because of some urinary incontinence. She'd also had some palpitations, and she was worried because her brother had died when he was 39 of a heart attack. Her father had died, and her uncle had died. There was a strong family history of cardiovascular disease, so she does have this increased risk. She had palpitations and was worried about those. And she was also worried about breast cancer because her sister had had breast cancer when she was 37. So I look in her last consultation, she was more anxious, her sleep wasn't great, she was more irritable at times, low mood, she had early morning awakening. So these are symptoms of clinical depression. She'd been seen by one of the junior doctors and he'd diagnosed, wrongly or rightly, depression and given her some antidepressants. She had tried 2 different antidepressants in the last year as well. So I've got her in front of me thinking, right, in 10 minutes I want to try and make her life a bit better because she's really having a horrible time. So then I say to her, because I'm very tuned into the menopause, when was your last period? She went, for God's sake, I'm not here to talk about my periods, I'm here for you to get me better. Anyway, my last period was 13 months ago. She said, everyone in my family has an early menopause, just something we go through, we just live through it. So I said, oh, okay, so are you getting any symptoms? She goes, well, yeah, I have hot flushes, but, you know, my mother had 30 a day. I only get around 8 a day. I said, what about at night time? Are you getting any night sweats? Oh, yeah, she said, I sleep on a towel, it's dreadful. She said, my husband goes mad because the duvet's on, the duvet's off, the windows are open, the windows are closed. So my sleep's really bad because of that. So work had been a real problem. In fact, she'd left work because her symptoms were so bad. So she said, I just can't remember anything at all. It's quite funny when my car keys are in the fridge, but actually when I'm forgetting things at work, it's terrible. Concentration's not great, and I'm quite direct. We've heard how common vaginal dryness is. So I asked her if she'd had any vaginal dryness or irritation, and she said, oh yes, she said, it's terrible. In fact, I used to swim a lot, and I don't wear a swimming costume anymore because it causes a lot of discomfort. And then I asked her about sex. We're very British, we don't talk about sex, but I do in my consultation. And she said, yes, it's really uncomfortable. She said, I haven't had sex for a few months, but the last time I did, it was like having a red-hot poker shoved inside me. I said, my gosh, did you not say anything to anyone, to your husband? She said, well, why would I? He was so desperate. I knew it would be over soon. We don't have sex very often. These are real women that tell me these stories over and over again. She said, but I don't feel like sex. I often wait for my husband to fall asleep before I go upstairs to bed because I'm really not interested. She'd been told by her doctor, because she thought she might be, menopause, early menopause runs in her family. But a lot of doctors said to her, well, you're too young. You're only 38, you can't be menopausal. And anyway, you don't want HRT, that's really dangerous. That's going to give you breast cancer. So, what's the diagnosis? What do I do? I'll come back to her at the end of my presentation. Another lady, she's a 57-year-old lady I saw in my clinic a few months ago. She had breast cancer when she was 42. It was estrogen receptor positive. She'd received chemotherapy, radiotherapy, and she'd had a bilateral oophorectomy when she was 43. She'd had 14 years of menopausal symptoms. She'd had a really rough time. She'd tried, according to the guidelines, quite appropriately different medications. She tried some herbal preparations. She tried acupuncture, CBT. Some antidepressants can be used for some of the vasomotor symptoms, the hot flushes, sweats related to the menopause, but she'd limited because of side effects. So then I asked her a bit more because I delve in. She had hot flushes every 30 minutes or so. These women sit there and tell me, and you think, gosh, for a day I would be really hacked off. She's had it for years, years and years and years. She was sleeping on towels. She said, in the morning I feel like I have a bucket of water poured over me. Every morning I have 3 or 4 showers just before I can get dressed. She said, there's no way I can exercise because I have really bad joint pains, muscle aches. She said, it's just awful. So I've stopped exercising. I am more irritable. I can vouch for that. When I had menopausal symptoms, even my husband's breathing annoyed me. I'm not joking. But she was more irritable. And her husband, this is really sad, her husband had left her 2 years ago. So she'd stopped working as a legal secretary because of poor concentration and a dreadful memory. Every afternoon she was falling asleep on the sofa and she'd put on around 2 stone in weight. So am I going to give her HRT? So just to whiz through, we've heard about the symptoms. I do a lot of work with the West Midlands Police, the second biggest police force in the UK, and we've had these put on the back of toilet doors. But one lady said to me, do you know, every time I go to the toilet I cry because I have all these symptoms and I don't know where to get help. We know it should be managed in primary care. This is some research that I've done through the Primary Care Women's Health Forum showing that doctors agree that it should be done, but they're not all confident, especially in younger women. There's a lot of confusion. 25%, these are women, healthcare professionals who have a vested interest in women's health. So they weren't aware of the different modes of administration and doses of HRT. They thought estrogen through the skin shouldn't be given to women with diabetes, which is wrong. And a quarter thought that any type of HRT increases the risk of breast cancer. We already know it doesn't. There's good guidelines. So all my work is done is based on the guidelines, the NICE guidance, there's International Menopause Society, and there's good European guidance for early menopause. And these aren't being adhered to, which I feel is a medico-legal problem in general practice. So we all know that individualised care is really important for women. Young women need to have hormones unless there's a reason until the average age of the menopause is 51. And for the majority of women, we've already heard there are big risks to health from not taking HRT. So the benefits outweigh the risks for the majority of women. And we've already heard as well, we can take it forever. I don't want to stop my HRT. I'm very scared about osteoporosis. The majority of women, around 70% of women I see in my clinic, are inappropriately offered or given antidepressants for their menopausal symptoms by their GPs. The current guidance say that we shouldn't be given. These are two different very common types of antidepressants. They shouldn't be used to ease the low mood associated with the menopause. We also know that estrogen therapy may actually improve the low mood and reduce the likelihood of having clinical depression if they're given in the perimenopause or menopause. However, in this study, 70%, which echoes my clinical practice, have either been given or offered, the doctors admitted they're given or offered antidepressants, which is against guidance. So I really strongly feel doing nothing as a GP or doing nothing for women who are early menopause or menopausal isn't really an option. There are different types of HRT. I've recently had an article put in the British Journal of General Practice talking about the advantage of oestrogen through the skin, and micronized progesterone, which is a natural sort of more body-identical HRT, a type of progesterone. These are available on the NHS, despite a lot of doctors not realising. So finally, just to go back to the lady, a picture says 1,000 words. I gave her HRT because of her age. She was young, she needed it. I said, I've got no idea whether it's going to help your symptoms, but you need it for your bones, you need it for your heart. Okay, she's got makeup on, but you must, I'm sure, agree that her hair has grown back. She's got a cheeky grin, she's got a job back, she's having sex. You know, she's enjoying life, and she wanted me to share this picture because she wouldn't want other people to suffer. And, you know, what was she of 38 carrying on like that is pretty miserable. And then patient 2 came back and we had a very informed discussion. I'm very fortunate in my clinic. I have half an hour, which is amazing compared to 10 minutes in general practice. So we talked about the benefits, risks of taking HRT. She tried everything else and she said, you know what, doctor, I just want my life back. So I gave her a very low dose of estrogen. She hasn't got a womb, so she only had estrogen. And she says to me, since taking the HRT you prescribed for me, I felt so much better. The most powerful change is that I sleep well. There's so much about sleep, isn't there? We know poor sleep increases the risk of diabetes, cancers, depression. These women sleep better when they take the right hormones. Miraculous feeling. Sleeping all through the night. Amazing. I have regained my energy levels, joined a gym. I actually go through the day without feeling like I'm going to fall over with exhaustion. So all in all, I feel very positive and want to thank you with all my heart for helping me. Thank you so much for your help, guidance and support. I never thought I would say this, but truly, you have given me back my quality of life. You know, I'm very lucky. I have the best job in the world and I do very basic medicine. You know, my husband's surgery is mind-blowing. She was very happy. She said to me, if I get breast cancer again tomorrow, I don't care. I've got my life back. So women need to make informed choices. It's really important that we give them the time and information and share that decision-making with them. Thank you.
And for our final presentation, I'd like to invite Diane Danzebrink onto the stage. She's a psychotherapist and menopause expert with professional nurse training in menopause and works as a menopause counsellor.
Hi everyone. I'm probably the only non-doctor, non-professor you're going to hear from today. And I come very much at this from the patient expert. It's probably useful for you to know how I got to be standing here in the first place. About 6 years ago now, I had to have a total hysterectomy. I had severe endometriosis, had for a long time. I had a condition called adenomyosis, which some of you may be familiar with, fibroids, and there was also the possibility that I had ovarian cancer, which my mother had had 25 years before. At the time obviously, total hysterectomy was the right way forward. However, I was not counselled at any point about the results of a total hysterectomy. Nobody sat me down beforehand and said to me, actually, I knew I would go into menopause, but nobody told me about what that entailed or what potentially that could entail. So my surgery was actually quite an emergency surgery because of the ovarian cancer and because they couldn't be sure either way. So consequently, I had my surgery. I left the hospital after 2 days being told I would not be called back for another appointment with my gynaecologist, but at some point, you know, in 6 or 8 weeks' time, I should go and see my doctor. Once the letter came through to say that actually I didn't have ovarian cancer, I was just, great, that's fantastic, let's crack on, I'll be well. I was really fortunate in 2012, you might remember we had the Olympics. I got to sit down on the sofa for the whole of that time and watch the Olympics. So timing couldn't have been better if you're a sporting fan. So this letter came through and I was obviously I was overjoyed. I'd suffered for many years with the results of the endometriosis and the adenomyosis, so actually having the hysterectomy for me was a positive thing. Fast forward a little bit, and because I didn't get the right advice and support either prior to or after my surgery, I was left very much to find my own way. And unfortunately, what that meant was my focus was on me getting well and getting back to work, which I kind of did within about 6 weeks. And it all went well for about 3 months. I decided I would go off and see a nutritionist, and they gave me 7 different pots of things to start taking, etc., etc. And it all seemed, it was kind of like, actually, this is not nearly as bad as I thought it might be. And then we got to about 3 or 4 months after the surgery, and my mood didn't just get low, my mood fell off a cliff, and I dropped into a really deep, dark hole that I don't ever want to go back to. I became essentially a bit of a husk of myself and a totally non-functioning human being. I used to run 2 businesses, that went by the wayside. I wouldn't leave the house, I wouldn't see anybody, I couldn't sleep properly. My mother had to be imported, bless her, so that my husband could go out to work because he was terrified of leaving me alone. I couldn't sleep. I would lay awake at night with this huge weight pressing down on me, thinking, if this is the rest of my life, I don't think I want it to be like this. Actually, I don't think I want it. And on one particular occasion, I came very close to acting on that. I told my husband almost immediately about that, and he rang my doctors, pretty much picked me up and said, you need to see her, and you need to see her now. And it was only at that point, when I sat down in front of the doctor, that anybody had ever talked me through HRT and my choices. And in that moment, when she said to me, there are choices, these are the possibilities, this is why you're feeling like you're feeling, your estrogen has gone, you're 44 years old, it totally makes sense. But nobody had ever told me that. And probably within 48 hours of slapping on the first patch, because I was in such a deep dark hole, that was probably the first day in several months that I'd kind of recognised sunlight, that I knew the world could be bright again. During all those awful nights when I sat anxiously in bed shaking, trying not to wake my husband, because the poor man had to get up and go to work and function the next day, I started to Google, because I thought, I wonder if it's just me. I wonder if I'm the only person that thinks that I'm going mad. And what was really shocking was that clearly it wasn't just me. But all these women had not had hysterectomies. A lot of these women were just feeling they were going mad. They didn't understand what was going on for them. And when I spoke to my GP surgery about a support service, about, you know, sort of where could I get support, I was told, well, there is nothing like that. There is no support service. And I thought, hang on a minute, are we not 51% of the population? How can it be that we're so poorly educated about something that's going to happen to all of us and there's absolutely no support service? So I said to my husband, not long after I got my HRT, do you know what? If I ever feel like me again, I'm going to make damn sure I do something to change this. And consequently, Menopause Support, which is a website that I run, was born. And Katie and I came together through the joys of the internet. And Katie asked me if I would link the Menopause Support Network, which is a private Facebook group that I started about a year ago. We're now about 4,000 members. If I would link that to it for women who were also struggling. About 20 years ago, I trained as a counsellor. Went off in a completely different career direction, but that time in my life, 6 years ago, completely refocused me. So I did some more integrative psychotherapy training. I did Kathy Abernathy's fabulous menopause training for nurses. I have spent an awful lot of time with the lovely Louise, who you've already spoken to, and I'm also supported on the support network by Renee. So now I work as a menopause counsellor. And should there really be a place for a menopause counsellor? Well, actually, if we trained our GPs properly in menopause, no, there shouldn't. If we educated women and men about menopause, no, there shouldn't. But because we don't do any of those things, yes, there is a place. And so my place, I was asked to speak about what is the role of a menopause counsellor. And the role, essentially, the very first thing, the most important thing that I do is I listen. Because for most women, when they come and either sit down with me or talk to me on the telephone or via Skype, they say to me, that's the first time I've actually felt heard. And that's the key, is that these women don't understand what's going on for them. The most common things that I hear are, I feel like I'm going mad. I've lost my joy. I don't know who I am anymore. I don't recognise me. And I have a fabulous job, but it is also a heartbreaking job. Because we shouldn't be in this situation. What the role, well, it depends. It depends what the woman wants. If you're coming to see a menopause counsellor, the likelihood is that you've kind of got some idea that something's going on for you. And so what we generally do is that woman talks about how she's feeling, what's going on for her. Very often it's to do with her capability of doing her job or what's going on with her relationship. So we have to remember we've got 4.3 million women over 50 in the workplace now. That's a 72% rise since 1994. We are very, very much playing catch up in awareness in the workplace for women. And approximately 1 in 10 menopausal women leave the workplace because of their menopause symptoms. Personally, I've counselled 4 NHS nurses in the past 6 months who have all left the NHS because of their symptoms, because they weren't supported by their GPs and didn't get the right information, or they weren't supported at work. I don't know what NHS everybody else is looking at, but the one I see cannot afford to lose nurses at that rate. It's about understanding. It's about empathising with where they're coming from and what it is, and actually listening to what they're telling me. So the symptoms that you've seen up on the board today, traditionally we think of menopause as being hot flushes and night sweats. It is so much more complex than that. And majority of the women I see, as Louise said, majority of the women I see have been prescribed with antidepressants. They've been told they're depressed. That's just ridiculous. So the key to what I do is actually empowering those women. It's giving them the right information, education, advice and support for them to then be able to go and sit down with their GP. And quite often, I refer them to the NICE guidelines. And don't get me wrong, anybody that's a GP in the room, I'm not blaming you for not having the information. It's the training that needs to change. We need to change training for our healthcare professionals, because if menopause was a really rare disease, I would say, I totally understand why you're not being recognised, why those symptoms are not being recognised. But it's not. It's a stage of life. It's not a disease. It's a stage of life that's going to happen to the majority of women, and 3 out of 4 will experience symptoms. One of my jobs is to signpost. It's to signpost those women to services and to actually empower them with the information so that they can go forward. And actually, to be honest, I've had a lot of really, really supportive comments from doctors saying, thank you very much, that's really helped me with my patient. We shouldn't be in that situation. I think, you know, sort of the key to what I do is I offer those women hope, because many of them come and they feel absolutely hopeless. And so that's really the key. Katie said that I could quickly mention that on World Menopause Day, I was in Parliament launching the hashtag Make Menopause Matter campaign. The Make Menopause Matter campaign calls for 3 things. It is to improve education for healthcare professionals, it's to improve awareness in the workplace, and it is to include menopause within the PSHE curriculum. So I would urge you, if you are a woman, know a woman, or love a woman, please go to the menopausesupport.co.uk website and sign the petition. Ladies and gentlemen, it has been both a privilege and an honour to stand amongst these people. Thank you.
Okay. All right, I'm afraid we have overrun, so we're just going to allow 15 minutes for for a quick Q&A. Well, in fact, Katie's got a question, so let's start with that.
So this is a question from the Facebook group, and you can decide who wants to answer it or you. It's from Gail Warwood, who says, is the hormone given in HRT the same hormone that is taken out, removed from the body via tablet, estradiol, for treatment of hormonally responsive breast cancer following surgery? And then her second question is, if HRT is made and introduced to the body synthetically, would it have a different, safer response in the body to the natural estrogen that is removed via tablet?
Okay, I'll start with that. Okay, well, first, there is a term called bioidentical hormones that's out. And bioidentical really means just estradiol, which is the dominant form of estrogen that circulates in normal mammalian women. There's estradiol, estriol, and estrone, and estradiol is the dominant form of estrogen. Bioidentical is used as a marketing tool. In the United States, the leading form of hormone replacement, estrogen, is commercially manufactured Premarin. Premarin is an acronym for pregnant mare urine. Why would you want to take well, it doesn't smell or taste like urine, but that's what it comes from. And there now is over 60 years of research experience with Premarin. I prefer Premarin only because of the extensive experience we have with it. Estradiol is the dominant form of estrogen used in the patch, whereas Premarin has 10 different forms of estrogen. One of the estrogens in Premarin is equilin, which is the single most effective treatment for brain preservation and benefit. I like Premarin for that reason. The patch is marketed as not associated with the increased risk of clotting that you'll often see with Premarin, and that's true. The patch does have a lower risk of clotting. It's not a high risk to start with, but it is lower. The patch is not as helpful for the brain and the heart. It's a choice that can be made by the physician after a discussion with the patient. Do you want to add to that?
Should we get more questions?
Let's get another question here. If we could move the microphone to the front, that would be great.
The latest missile from the WHI, headed by Diane Danzebrink, still says that these hormones are not for chronic diseases. Why do they keep saying that in every publication?
That's an excellent question. And Carol, my co-author, and I, we wrote a paper for The Atlantic, which is a magazine in the States. And they said, we really like your paper and we'd like to publish it, but, and they asked that same question, why are you in the minority if what you're saying is valid? And the first answer is, I don't have a good answer for that. These aren't evil people. These are people who believe in what they're writing. The data do not support what they're writing, but they believe in it. There's an excellent study, which is a kitten study. Kittens that are raised, kittens from the same litter, raised in a vertical environment where they are exposed for 6 months to an environment that's only vertical stripes and then they're put back in the dark, are compared with their littermates who are raised in the same environment but with horizontal lines. And you then, after the months of the study, put the kittens in an environment with high chairs. And the vertical kittens have no problem navigating between the legs of the high chairs, but they have no concept of a chair that's up there that they can jump on and lie on. The horizontal kittens see the horizontal seat and they can lie on it, but they keep bumping into the legs. I think if breast cancer is the only thing you see and the only thing you focus on, your brain isn't working in the open way it should be. The last book before this book that Carol wrote with me is a wonderful book called Mistakes Were Made, But Not By Me. And we're all guilty of that. Yes, I'm sorry. I think she's...
Oh, hello. Yeah, I don't want to appear rude, but all of the other speakers at the start of their talk, they disclosed their conflicts of interest. And I just wondered if you had any to disclose. I
don't think that's rude. I think that makes a great deal of sense. The short answer is no. I have absolutely no conflict of interest. As a practicing physician, I didn't even see detail men who came to my office with pens and whatever because I don't get my information from detail people. I was hired once as an expert witness by the makers of Premarin who were being sued in a class action suit for breast cancer, but I was hired because of the articles I published, not because I was on any retainer, and they just paid me for my time, and that's the only relationship I've ever had with a drug company.
Thank you.
Thank you for asking.
Microphone, the back lady in the pink cardigan, and then I'll come to you.
Thank you. We touched on this morning about how the premenopausal cohort may be underserved by the research and the studies that are out there. You'll be aware of the text and soft trials which prefer aromatase inhibitors and ovarian suppression now over tamoxifen. But what you talked about there was about this issue about suppressing estrogen and how that causes problems later down the line. So do you see an issue with those studies that are pushing that premenopausal cohort towards castration as opposed to the tamoxifen route, which seems potentially a softer option?
Yes, I do have an issue with it, but the issue will become apparent over the next several years. As a medical oncologist, I support that conclusion that in fact the aromatase inhibitor, which inhibits estrogen production, together with something that inhibits the pituitary gland from stimulating the ovary, is more effective than tamoxifen. First, be aware the difference is very small. It's made to sound, well, why don't you take advantage of every percentage point benefit that you can get, but it's really very small. There is now attention being paid to the heart ramifications of what we're doing in treating cancer. And when we eliminate cancer, it's not enough. We still have a human being with many different problems that we have to deal with, and that's going to become more and more apparent with the passage of time.
Thank you. And, oh, yes, over here.
Siobhan Laws, surgeon from Winchester, treat breast cancer all the time, and we often prescribe tamoxifen aromatase inhibitors. And what I was concerned about from what you've said is the balance between the quality of life issue. How do you go about practically in your practice when you ask someone to take tamoxifen or an aromatase inhibitor? What do you do about the HRT? Do they take them together? Do they have a gap? Do they have a period of time before you would start the hormone replacement therapy?
One of my favorite lyrics is from the movie Yentl, where at the end Barbra Streisand sings, "The more I live, the more I learn, the more I learn, the more I realize, the less I know." And in something like this, I try to be very, very careful. There was a prophylactic study looking to see if women who had unilateral breast cancer, who were given tamoxifen, had a lower risk of contralateral breast cancer, and the answer was they did. These were premenopausal women, pre and post, and they had a lower risk, again, small but a lower risk. The UK did a similar study, but they allowed women who were taking tamoxifen, this is before we had aromatase inhibitors, to take hormones as well. And they found the same benefit that we saw in the United States. And so I think a decision has to be made if a woman is taking a drug, especially something like tamoxifen, whether her quality of life necessitates that she take something to help her get through that period. There's a problem with aromatase inhibitors, and I purposely didn't mention aromatase inhibitors in this presentation because aromatase inhibitors, which are just given to postmenopausal, not premenopausal women, are believed to work by inhibiting the synthesis of estrogen. I said tamoxifen works by at least 10 other ways. But if they work by inhibiting the synthesis of estrogen, then it doesn't make logical sense to give estrogen at the same time you're giving an aromatase inhibitor. And so I don't. And I don't have a good answer for your question in that situation. Yes? Could you use the microphone?
Sorry. We still have the problem of whether we can advise patients to use the Mirena device for contraception because of the small amount of progesterone that might be absorbed, or using vaginal estrogens. And one of the biggest questions we get from GPs is, can we use those in breast cancer patients? And that the amount of
vaginal estrogen is simple. I think vaginal estrogen, the amount of absorption is so small, it's a non-issue. And the benefit, I mean, I would defer to...
Absolutely.
Okay, right. The contraception, I'd have to talk in more detail about the dose that we're talking about and its mode of action, and I can't give you a simple answer to that.
Thank you.
I'm sorry for...
Hi.
Okay.
Really for Louise and Diane, I guess, just because working in the UK. We talked earlier about health economics and breast screening, and I actually think with HRT it's almost a no-brainer. If there weren't men involved, we should put it in the water, because we're asking women to work to 68.
Talk in the microphone a little better.
We're asking women to work to the age of 68, and lots of them, as we've heard, can't even cope past 50. They can't function, they can't get out of the house. They are carers, they are mothers, they are partners. We are, as GPs who are not educated, are sending them off to rheumatology clinics because they've got fibromyalgia. We're sending them to cardiology because they've got palpitations. The cost involved in all of these referrals, when actually all they need, the cheapest chips patch or tablet, is unbelievable. And I just wondered if you two guys obviously felt the same, seeing people day in, day out.
I probably feel even stronger, actually, because it's driving me, it drives me crazy when you look at the health economics. And the average patient, not that any woman is average, who comes to see my clinic has seen at least 3 or 4 GPs. Most of them have been to a secondary care, and most of them have had investigations. But it's cost to the NHS, but it's cost to them. It's cost, this lady, she's going back and forth. She thinks she's got heart disease. She thinks she's got a brain tumour. She's having these scans. She's having tests. She's having to take time off work. It's all this. We've talked about the overdiagnosed problems with breast screening, but actually not diagnosing the menopause, which we all go through, is even worse. And, the cost is huge.
So everything you've said, Renee, was in the presentation to MPs on World Menopause Day. You're absolutely spot on. We've got personal costs to women, to their lives, to the finances of their families, to their relationships which are breaking down. We have cost, we have socio-economic cost. We have women who are claiming benefits for the very first time in their working lives. They've never done it before. Huge cost to their self-esteem. We have a cost to business and industry where they're losing hugely valued members of staff because those staff aren't being supported either within healthcare or within the organisations. As I said to the cross-party MPs last week, this is a win-win situation. This is simple medicine. This is easy to resolve. We just need the will.
One more question here from Katie.
One question from the group, which I promised I'd ask, from Joe Amit. I was menopausal and the symptoms come and go. I'm almost 51. My mother and her mother both have breast cancer, and I cannot take HRT as much as I really, really want to. I'd love to know from an expert what my alternative options are. The flushes and the mood swings can be so fierce sometimes, I'm really tempted to demand HRT.
Go ahead and demand it. Timothy Rebick, working at the University of Pittsburgh, said that we now know that there is some genetic predisposition to breast cancer. The most widely known one is the BRCA or BRCA1 and BRCA2 gene. And there, women can have up to a 50 or 60% risk of ovarian cancer and a 20 or 30% bottom line risk of breast cancer. And so there, women have been oophorectomized, they've been castrated to reduce the risk of ovarian cancer, which does reduce the risk by about 85 or 90%, not 100. And interestingly, these premenopausal women who are oophorectomized, because they have their ovaries removed, have a 50% reduction in the risk of breast cancer. And so people have said, there it is. Do you need more proof that estrogen is responsible for breast cancer? Except Dr. Rebick said to these women who were markedly symptomatic, like you, I'm going to give you estrogen. And he did. And the 50% decreased risk was unchanged. In addition, Dr. Eisen, working in Toronto, gave BRCA women with a known predisposition to the development of breast cancer estrogen replacement therapy. And what she found is a decreased risk of breast cancer development. So that one has to be very careful following an ironclad guideline that isn't based on data.
Would you advise those women to get checked more regularly or anything like that? Or?
The answer is of course. I think you have to define what you mean by checked.
A discussion about screening this morning. I deliberately avoided that word.
As physicians, we feel tremendous responsibility. I mean, just parenthetically, I have several hundred women who are taking HRT on my study who know that if I come across any data that suggests it's the wrong decision, I will let them know and they will stop. I retired from active practice a little over a year and a half ago. And I am still in touch with those women who call me at home or send me emails. And I feel responsible keeping them informed.
I think we should let you all go and have some lunch, but thank you to all of the panel for an absolutely fascinating